Well, we are live. We are streaming our Gender Exchange online series. It is the 2nd of November, 2022. We have a very special guest with us tonight. We have Dr. Nomsa Buso. She is quite the gender diversity and sexuality expert, as a medical expert, as a professional, as a medical pioneer. So I'm going to be talking to her today, and I'm going to also just give you a little bit of background around the work that she does very quickly. But for those of you that are joining us for the first time, welcome to the Gender Exchange online series. My name is Nosana Sondiyazi, and you're probably wondering, how do you exchange your gender? Do you hand over your current gender and take over another one at the till? You just buy it at clicks? No, that's not really how it's done. It's not that simple. How do you exchange it? Is it through other fluids? Is it through other romantic interactions? So if you've got any questions, please ask us, because what we are exchanging actually is ideas. Because gender is a mental attitude. It is your personality. It is your position in life. It is how you express yourself. It is not your sex, your biology, right? So it's very important for us to actually understand that a person can be one sex and a different gender. So we've been talking to people who are transgender, non-binary, people who are performing their gender. We're talking to doctors. So it's actually very important that doctors come in on the conversation, because if your doctor doesn't agree with you when you are telling them the gender you are, you need to let your doctor know about Dr. Buso, all right? So, doctor, I'm just going to go through a very short bio of yours before I welcome you.
At least I have a bio.
Yes, you agreed. You agreed that this is your bio, that you are a sexual reproductive health service practitioner, as well as a transgender healthcare practitioner, a medical termination of pregnancy service practitioner, as well as doing HIV/AIDS management. Thank you so much for joining us, Dr. Nomsa. How are you? Welcome. How are you feeling?
Thank you so much. That's quite a bio. Yeah, I'm just pleased to, be amongst people that appreciate me for who I am, and I'm happy to help where I can. For me, if it's anything for marginalized people, populations, rural populations, it makes my heart tick. So I always do the best and provide the best that I can in the best way I know how. So thank you for welcoming me into the platform. Finally, I make it.
Thank you. Thank you so much. And I'd like to say hello to your followers on your other pages and on your other socials. Thank you so much for broadening our audience today. Because the lovely thing about the internet is, as much as we're based in the Free State as an organization, but Molemo, the internet can actually, over the weekend, we were in Angola, for an example, right? So when we can help each other and talk, and because we're lucky enough to be right in central South Africa, we're hoping that people just plug in and go like, hey, you'll be passing through from Cape Town to Joburg, pass through, pop by. We right in the middle, right?
Yeah.
So anyway, Doctor, can we please go straight into it? We've got some wonderful questions that we're excited to have you engage with us on.
All right.
And the first one is just giving us a little bit of background on you yourself. If you are so passionate about marginalized communities, and you are so passionate about the work that you do on gender diversity, where does that history come from? How did you get here? But also take us from very early, maybe from your childhood and your background. Please just give us a background on where you come from.
Oh, okay.
If you don't mind, thank you.
Thank you, Nosana. Growing up as a child, I was very shy. I was quiet, basically. And because of my body size, and you can see I'm still thick, people tended not to like me, and I experienced a lot of bullying, especially at school, and I think I grew up then a little bit withdrawn. But one thing that I learned early was that I had intelligence, because I went to a Roman boarding Catholic school, and the so-called big girls used to bully us so much, and my heart used to bleed, even though I wouldn't answer back. Then I later learned that even though most people hated me because I was thick, when it came to mathematics and physics, they had to grovel. They had to come to me, because at the end of the day, they wouldn't leave class until our maths teacher, they had all the sums, So that gave me confidence to know that I have something that other people don't have. And there is things that they are better at. They may be looking slim, fabulous, and know all the songs. And while I came from the rural areas, I remember when they made us dance, when they welcome you into school, and mina ngangisenza pantula. And I actually like pantula dance because it's back. So everybody was laughing at me, ha usukaphi lo owenza isiphantsula esuke ezilalini, and now you're in this English school, everybody's speaking English. So growing up, I grew up in that kind of environment where I had to just fight for my existence and being noticed and stuff like that. But the nice thing is I did it through my books. I did it through learning, through inquiry. I remember I wanted to be a pilot, and my father, is a priest, and my father is so intelligent. He had his way of diverting me from becoming a pilot by engaging me so much that I didn't have questions any further. But anyway, I still love him, and I love what I do. And then going into medical school, it wasn't easy. I didn't even have money for medical school, even for the application form. When I went to submit at like 12, I still was trying to figure out how to fix my documents and submit. So it's not easy, but I just persevered. And luckily for me, I was always someone who was a hard worker. So most of the then TEFSA, we used to call it TEFSA, the NSFAS now, it became a bursary because I really worked hard at school. But one of the early experiences that I had into, diverse gender care or exposure to it is when we went to the sexual reproductive health clinic in our training hospital, which was in Nkosi Albert Luthuli then. It was fairly new. And there was a child that was born with ambiguous genitalia. And, in labor ward, usually when a boy is born, there's like a shout, oh, it's a baby boy, or it's a gay baby girl, And this other time in theater, it was not the same. There was a lovely, big, screaming baby. But the silence in that theater, you could cut it. You could cut it. You could hear a needle fall because it was so quiet. And I didn't understand because the baby was coming out loud. No one was running around to resuscitate or anything. But it was just this stillness, and that broke my heart because there was this human being alive, bubbly and well. And because they just happened to have two genitalia at the same time, there was no jubilation or celebration of that life. So that's
the mother so much.
Yeah, so that's the first time I really got exposed to a diverse gender care, or let me just say, something different from what society has been teaching, or even what medical school had taught me.
Wow, and the intersex gender, the ambiguous children that are born with ambiguous genitalia, they're often kept a secret and they're often hidden in society. I know of stories where there's an intersex person in the family who is hiding it even from her siblings, So
yeah,
that is very scary, that you can't be proudly just a person, because now people can't be sure whether they can classify into this box or that box. So that made you interested, and that's when you decided, no way, you're going to do something about this.
Yes, and later, while I was learning as well, Then we went on to go to the endocrine clinic, gynae endocrine. And there was a lot of parents who had similar children, and they actually were made to choose what genitalia they wanted to keep for their babies, And later as I was doing HIV and AIDS, I also learned that there are some that earlier in the years, even before there was Albert Luthuli, there were these children in King Edward, and I was not aware of that. And unfortunately, some of them, if the parents chose for them to be male, then when they got to puberty, they wouldn't develop any male secondary characteristics. However, they would develop female secondary characteristics.
Like start menstruating and you've got a boy child, right?
Yes, and now there's growing some breasts, and they're not developing any beard, or they're not developing any deep voice. The Adam's apple is not showing as expected. And there was so much of mental health with these people. And it was not because they were born with a low IQ, but because of the pressures that they had to deal with growing up. And at that time, what was now the changes that were occurring in their bodies. And we saw quite a lot with of suicide as well. And sometimes it was not even documented, because when you would later follow up, you wouldn't get much of where they are coming from. And sometimes they were treated as specialized cases more than, a human being suffering because some people have decided on their lives.
Oh my goodness, but they're not doing that anymore, right? Isn't it now been made into law that parents can't decide for their babies, that you have to allow for your child to grow up and decide for themselves what genitals? Are we practicing that also in South Africa?
Yes, we definitely are practicing that. There has been a lot of changes, Nosi, and there's a lot that practitioners are also learning, because remember, when people had gender dysphoria, initially they were diagnosed as having some mental or psychiatric illness, So there has been a lot of transition to understand that gender dysphoria is not psychosis. It's not someone mad or going I don't know how to describe it, how it was described before, but there's a lot of changes in that. And you can even see, even with the South African Clinician Society, they have actually even taken out guidelines that can be used by primary healthcare practitioners to assist, with gender diverse care in general, not necessarily a hormonal therapy, but in terms of caring for gender diverse people. And we have been going through workshops in the different provinces. I think that's where we met with you as well, to say there is practitioners in the primary healthcare setting, in the rural care setting, that are able to liaise with people on a general public basis.
So let's quickly break it down before we go too deep. We've gone and now talked about intersex, but some people are still a bit confused around, but how can you have both genitalia? How can you be the third sex? So can you please just take us through what is your sex, what is your gender, and what is intersex? Yeah.
All right. Sex is what you are born with, Nosi. If you are having female genitalia, your sex is, you have a vagina, right? Yeah. And then that's what sex is. And then if you have a penis, then you are termed, you have a male, then the sex is that penile part, which is your private part. So you are either having a vagina or a penis, right? Yeah. And then gender is who you are, how your formation has come to being. For an example, that we have female people, that means people who are identifying as female because they have a vagina or a female part. Those people we call cisgender, because what they were born with, is identifying or conforms to the societal or social norms of what or how people think a female person should be acting. And that as well is supported by studies where in the CT scan of the brain, even before the person is born, they have a female part, and their brain activity on the scan, the blood flow is showing in a pattern that is female-like. So there are female hormones, there are female genitalia, and also what they come out with, then they conform to that societal norm. But at times, someone has got a female genitalia and their brain activity, even on CT scan, is directly opposite and depicts the brain or the flow of blood shows that of a male, and those people, they may have the female part, but they are who they are is actually male. It's opposite to what the genitalia is outside. And one of the examples I usually make, people know that there are people that have got a female genital outside, however, they do not have a uterus. Even though they have a female genital part outside, but when you follow inside, they don't have a uterus. As a result, they'll never have menstruation or anything else. Some of them may even have male gonads, but some of them don't even have those male gonads. They may have the female ovaries, but without even the uterus itself. So it's those, because not all the children at birth are scanned to see that all the body parts are there, because we know some children, they have the eye socket, but they don't have the eyeballs, or they may have the socket and the eyeball on one side, and then they don't develop the socket on the other side. So we have a lot of people that outside they are looking like they are female, but inside they don't have all the female organs that they need to have to conform to, reproductive health that is normally known by the society. So that is what transgender would be, where someone has got this genitalia, but their formation and who they are and how they identify is opposite to this genitalia they have. And then with intersex, like I've just made an example that some people will be born with a socket without the eye. Instead of having one set of genitalia, they actually have two genitalia. And at times, both, where they were supposed to sometimes be the clitoris, they actually have a fully formed penis. Yet they also have the vaginal opening. And at times, where they were supposed to be the testes, there is actually those are the labia majora of the second genitalia, and those are the intersex people.
And the intersex, I understand no intersex two individuals are the same visually and chromosome load. So you can't expect to see, if someone says they're intersex, that they look like how you describe. There's various types of genitals and inside as well. And that sometimes it only appears during puberty, that the genital will look like, okay, this is a vagina, this is a penis. Then during puberty, there's a change, right?
Yes, most definitely. That's so correct. It's also with the same with all other cisgendered people, or if someone would identify as a male or a female, they would develop a penile shaft. However, only to find out, they'll say, no, they've never even recognized that in their scrotum, there is no testicles at all. And when they actually go and look for the testicles, they will find one, or they will find two, the testicles joined together like a kidney, and it's one set, So there's all those ambiguity, even within sexuality of other, what we call heterosexual people or cisgendered people.
So now we are talking about so many variants, and it's so easy for us to call somebody who is looking typically like with their genitals, the one sex, we like to call them normal. And then anyone else that looks different, we like to call them funny words. So that's why the word cisgender is there also, so that if you agree with your brain and your body, your genitals and your sexual orientation or your everything, please just explain to us why it's important for us to know the term cisgender, considering that we like to use words like normal and then everybody else is going to be falling under another category. Yeah.
You know, the cisgender, transgender is actually like a describing word because we like to box people. You know, we just like to box things and understand them better. You know, humans like to be superhuman and be, you know, the best God ever. But it's just basically for the minute brain understanding for people to have an idea what they are talking about. Because even with cisgendered people, there's a lot of diversity with them to say, even though they conform to saying I'm male or female, but their sexual expressions, their romantic interests may be completely different to what the society is expecting or knows, or they may just be doing it in the public. But you know, they say character is who you are in the dark, and in the dark you do not know what they are doing. So cisgender basically means the genitals that you are born with are also, you also conform or they go along with what society expects a person with that kind of genitalia to be acting. So if you have got a genitalia of the penis, then you identify yourself as well. You feel like, okay, I'm a male and I'm going to wear blue, or I don't like pink things and whatever else, you know. So that's what cisgender is. It's nothing you know, it's not a complicated term or very scientific. No, it's just to say the genitalia conforms to what the people are thinking out there on the street.
No, the reason why I like to emphasize this is because when people don't know the term transgender, and then
Yes.
they find out that somebody's either non-binary or gender non-conforming, and they're not cisgender, they'll be like, okay, so what are you? Okay, and
then
then
you tell them that I'm Nosana Sondiyazi.
exactly, I definitely know that. But then now we are educating people a little bit, yeah. I mean, some people are kind of looking at these two sexes or two genders, and they're not even satisfied to classify themselves there. And that's why there's terms like non-binary and gender non-conforming, you know? So how does one, what are some of the common reasons why someone will identify as non-binary or gender non-conforming? I'd like to know.
There's different reasons for that, but also when the mind has been transitioned, because there's transitioning of the mind and decolonization of, you know, prior learned things, where we are able to learn and relearn, unlearn and relearn things, then we necessarily see that the conformation or the descriptions that are given to male and female, I do not fit into either. You know, my personality, my expressions and everything, they're not fitting into any of these things. Unfortunately, in the traditional South Africa, or I mean, as a South African child, let me say that, and some of the African people that I've stayed and lived with, you know, from Swaziland, Botswana, a child that was not conforming or was not acting according to what is expected of girls or boys, usually those children, they'll be moved to what Dobawo, who stays in Swaziland. And once now this child who is supposedly a girl is starting to act like a male, then they would be moved from that area so that people do not see this child who's seen as an outcast, sometimes because they don't know how to deal with them. And one of my friends and clients, you know, from Limpopo also said that in their family, they actually have 3 generations of ambiguous genitalia. And those people were actually taken to the mountains, you know, as an outcast. They didn't want them to be seen. And, you know, he's also dealing with that as well, because he was termed a female, and came puberty, there were no secondary female characteristics, and there were male secondary characteristics. So they were tended to be an outcast. into the family, you know. So I don't know if it really answers you, but it's some of the reasons that people cannot conform to what society knows. As a result, they would present themselves like that. But as humans, because we like people belonging somewhere, I want to be butch lesbian there. I belong to this group, you know, I want to be less butch and whatever it is. It's all people because people want to control and rule over other people, you know, take control and be seen to be more important than the other. It's like really nothing to it more than politics, you know, human politics of living.
It's actually become a bit cool, I must say. I must say I'm fortunate to know gender non-conforming and non-binary people who maybe have got the privilege of maybe being educated and being maybe claiming their bodies and claiming their non-binariness. Because now you were just talking about a butch lesbian, but now there's even studs. I don't know if you've heard of a stud. A stud is a good-looking butch lesbian, a slim, good-looking, you know, with the tattoos and the dreads and the yellow one. I'm like, oh my gosh. So yes, there is that history that comes from like pain and being outcast and being, you know, shoved out of the community and being an embarrassment to your family. But I'm loving how there's a modern culture of like just claiming your non-binariness. Because now, if you're going to be non-binary and say you're androgynous and you're not slim, for example, because also body size plays a part into which box can I squeeze into. So now if you're non-binary, if you're really going to pull off being non-binary and then you're large, né? There's also something that you have to prove about, oh, okay, can I call myself this? Will I be accepted as that? So for me, I just actually wanted to add also that non-binary is kind of also your own political statement of just choosing that I don't like the options out there. You're not going to call me male or female. I'm claiming that I'm non-binary and it's in a modern space. Do you know what I mean? Like it's just in a modern world of no, my, their, them pronouns, you know?
So, you know, for me, Nosana, it is easy for people that speak English. Mina ngisebenza ezilalini, yabona? And indlela esikhule ngayo, or how we have been grown up, we've grown up with a sense of respect, you know, for someone older than you. But sometimes it's not because someone is older, but by the fact that it's a boy, to make them feel welcome in the home, everybody will be calling them ubuti or ubutana, you know, that's how they've been growing up, you know, or they'll be calling them usisana because of how they've been socialized. So when they say sisi, it's not necessarily that they are saying you are a girl. They are just giving you like this is how we respect you. And you know when something is coming out of love, but there are times where people are using their binaries to spite people who they see that are gender non-conforming. However, I always tell my clients that if you are gender non-conforming and your pronouns are they and them, let's find pronouns in vernacular language that are going to be acceptable to you, because it is difficult for people to learn and relearn things, especially our elderly. So if they've been used to saying to you, Nosana izapha sisi, you know, unzima for bona uthi, if they want to now say Nosana izapha them, uyayiva ne? So kufuneka sifune a language that is acceptable ukuthi now that I have transitioned or I'm not gender confirming, I have found who I am. This is how I would like you to call me. Let's help the people to learn the language. Let us not, of course, sometimes when you've been telling people over and over again, but let's just remember, language is so important, and it's one of those things that we need to continue to teach each other and learn. Like you are saying, you were not aware of, you know, a lesbian who's sleek with dreads and slim and very good looking, you know. So it is the same thing with language. That's something that we need to do, and that's something that needs to come from us. And we cannot blame people for continuing to use respectful words when they call us. Sometimes they're doing it unconsciously because that's how they've lived all their lives. Now, how do we educate ourselves to know what should bother us and what shouldn't bother us?
That's very important, you know, and that's when you actually let the children educate us. A friend of mine a few years back, I was a little bit androgynously dressed, and she was with her niece and her son. And then the niece just came up to me and said, Malume Elsie, you know, just a child who was like 3 years old, Butsisi. And it reminds me of this album, Kamajola.
Yes.
This Amukhanyisa Puti, uba ungubutsisi yena, you know. So like these are like some of the words, the ways in which, if we kind of normalize that middle place, that mixed place, because Nyani, how are you going to them somebody who's non-binary? And I know that now if I'm in a certain area and I know that I'll be with elders and, you know, people from, you know, as Lalini, I can't be strict with my non-binariness when I'm there, you know what I mean? But yeah, it reminds me of my friend's nephew who called me Malume Ausi. That kid just decided about, oh, I see you've got boobs, but I see that you dress like a man. So you both, you know what I mean? So
yeah, but you know, in that same breath, some people are actually embracing that because there's a lot of language gap and zininzi izinto where people abakakwazi ukuba bazawuthini na, ne? But some people are actually, there's an area like in Johannesburg, if you say Butsisi to someone, you've insulted them in the worst possible way, you know? So it is also we need self-development in the gender diverse community. You know, we need self-development where we need to increase our SQ, our EQ, and our IQ all at the same time. And we need to move fast, because if all those areas are developed within yourself, then there's a few things that will move you because you know who you are.
No, absolutely. So now let's please talk about Turtle Care Foundation. That's your practice, right?
Yes. So, that's my practice. Let me say something quickly. I really want, I'd love us to go a little bit into a little bit of hormonal therapy in terms of HRT, because there's a lot of my clients who are like, doc, you know, there's a lot with they're telling us about contraception and all these things, you know. So Total Care Foundation it's like a foundation from which I'm employed and operate from. It's 100% Black owned and fully women owned. And I am the founding and clinical director. And I do clinical medicine in HIV and AIDS, hormonal therapy. I do see general practice patients, but most of my clients are HIV positive. And I have also, you know, what we call discordant couples. I've got quite a few discordant couples where one partner is positive and the other is negative. So we are the prep started with us, you know. So it's a practice like that. It's a diverse practice like that. And where I met most of the gender diverse people was with partners that are said to be heterosexual, and we developed relationships where we were, as much as treating the HIV, some were disconnected, some were not. Then I would find out that this married heterosexual couple will come together, treat them, and they go. But one of the partners will now come back with a same-sex partner behind the other's back. And you know, as doctors, we're supposed to keep confidentiality, and these are clients that are trusting you. So you'll find out that you are treating one partner and with 3 different partners. Because
Mm.
yes, you'll find out that they have the married wife, and then they've got the cheating girlfriend, and then they have got the lesbian or the gay boyfriend or girlfriend that they come with. So it's the same person, but comes 3 times with 3 different partners.
Oh my goodness. And during the conversation with each one, you have to treat the partner as the exclusive partner.
Yes, you have to treat the partner as the exclusive partner. And at the time, it was so difficult to divulge. For an example, you wouldn't give out information to the other partner about the partner without their permission. But at least now the law says if that person is not stopping a certain behavior and they have a married partner and stuff like that, you are able to do that. And some of them, they actually knew about the other partners. So even though they wouldn't come and support the partner when they come with the other partner, but they actually knew that the partner was having these different partners, and they were just keeping the marriage or the heterosexual marriage as a social contract to be acceptable by all the families.
Yes, sure. And that's where index testing comes into play, I suppose.
Yes, yes.
So that
So
is actually good that they were discordant, that it means that the partner, whoever which one is HIV positive, then they're able to practice safe sex and keep, not contracting the other,
yes, and also because we learned early in treatment of HIV that if someone was taking their ARVs religiously and they were suppressed, then their viral load was extremely low, so their chances of transmitting HIV was actually low. But I still found the discordant partners. I found positives with the males that were having sex with males. So if the discordant partner was negative and the male was positive, now you would find out maybe after about 6 months, even though you were giving them lube and you were giving them a prep, or in fact, we used to give them post-exposure prophylaxis at the time. Some of them still became positive, even with that post-exposure prophylaxis. So PrEP was better because it meant that if the person was negative, as long as they're involved with someone and it's high risk sex, you can still give them and prevent them from being affected by HIV and AIDS. It's still happening now, Nosi, and we're still having a lot of people that are getting new infections, unfortunately, because we don't actively now want to ask people about HIV. People continue to spread and get involved in unsafe practices. There's the factory, where people are just having sex with anyone in the dark without knowing what's going on.
The factory.
Yes, there is actually. You do not know what the factory is. Okay,
Which one is that?
It's like let's say it's a nightclub where gay men, or even let's say men, will have sex with other men, whether they're gay, heterosexual, but that's where they go and entertain themselves. And usually it's dark, and some people will pre-order people because they know them. They would just want to have sex with that kind of male. And then there is enema, like an enema by the door, where you enema to clean because you need to prepare, your rectum for anal sex. And then, you just have sex and continue to have sex.
There's
So
factories everywhere. Factories all over South Africa.
There's factories all over South Africa. They may not be called the factory in other areas, but in Joburg, it definitely is called one. And in Mpumalanga, Limpopo, Eastern Cape, there's a lot. There's a lot that is going on. Even
and there's no condoms, no lube, just enemas at the door.
Yes, if there are condoms, there is lube, but I don't know how many people use them, but I do have clients that actually come saying, because I wanted the money and the only place to meet was that, and my partner that was going to offer the money at times did not want the condom, then there was nothing I could do, because it's something that gives me more money. At times it's like that, but there's also a lot of young males that get raped, anally. And we are even in the Tutuzela Care Center where I work, we're at in the South Coast at Port Shepstone Regional Hospital. We are seeing quite a few males that are being raped in church, that are being raped by their brothers, their uncles, after school, and all that. So we are seeing HIV new infections from all these sexual practices that are unsafe.
Oh my goodness, that is terribly tragic. So we need to enter these spaces and kind of, because I think there's the shame and the secrecy in entering these spaces, and now if you're going to go, then that there's money and you're going to be completely removed from your own choices of using a condom or not. You're just highly putting yourself at risk just because you need the money. Oh my gosh, that is
but
really,
even there's a lot of still myths where people actually are refusing to use condoms, like I can't eat a banana with a banana peel, and all these myths that we have to demystify and all these things. But there's still also people that are raping young girls because they still believe that they'll be cured from HIV and stuff like that. So we're still seeing those things. And also we still have people that are in denial about their HIV status, and they actually do not take the ARVs. And we are still having children that are infected with HIV, even though the percentage is really low, But it's things that we need to continue to speak about and talk to. So
you are working all over South Africa. Right now you're in Namtata, but you are working in different. Where all are you working?
Oh yeah. I work with Vets RHI mainly in their HRT clinics that is in Buffalo City in East London. And then I also help out in the Joburg clinic when there's no one there. And then I'm in private practice in the Eastern Cape in Flagstaff. And in Umtata, I am doing mostly mobile or virtual consultations because I've got clients that are there. And then in KZN, I'm mostly working in the forensic clinic where I'm seeing all these rape cases and stuff like that. So I just try and be diverse to just try and.
Oh my goodness! But let's quickly dig deep into what you are doing then. You've spoken about the HIV work you're doing. Let's talk about the transgender healthcare services that you're offering. Are you doing that? Can a person contact you directly, or do they need to find you in different spaces where you are, different places?
Yes, they just in different spaces on Facebook, on Instagram, on WhatsApp. I always answer messages. The only thing that I've learned is that at times gender diverse people think they're charity cases, and I put a stop to that. I don't do any services for free because I need to also live. However, I also need to maintain being able to provide the services because the traveling is coming from my own cost, but I do it because I know people need it. And there's a lot of gatekeeping that's still going on, and at times the programs that we are getting, for an example, USAID will say, we'll give you to run the program, but we will not provide the HRT itself, and then now you have to go around to get people to have some HRT at basic clinic. And sometimes when you are educating doctors or being in an educational space like this, they think it doesn't cost any money. So you have to be able to maintain those services even for future generations. So I always encourage gender diverse people to find ways and means to make sure you are able to support your life. Even if you are getting the 350 grant, put aside money for your health, because this is you, this is about yourself.
So you can also prescribe HRT, and you can, like, if we link you, you can prescribe HRT whether a person's got a prescription or not, or first you can also do a consultation and first assess if, and then only prescribe after that.
Yeah, I definitely always have a consultation first. An online consultation is adequate as long as I also get the blood results. And most of the time, what I do, for example, the clients that I have in the Free State, I will send them to their local doctor. and they will go and pull bloods or to the lab, and then I'll request the doctor to let's say do a fasting blood sugar on the client, because the doctor knows what a fasting blood sugar is. So they'll just go to their normal general GP. They go and get an assessment, then I will ask for that and do those blood results and then go with them. And then we've got a virtual psychologist that also does virtual consultations, and we meet there with them. Where I usually travel, like I'm in Umtata today, I'll use one of the doctor's friends' rooms that are people that are, allies to the LGBTIQ community. And then I'll go and do an ultrasound guided pap smear, because at times for the trans males, the vagina is so constricted and small that you don't want to be pushing stuff. So it's much better to do an ultrasound guided pap smear, where you just do the pap smear and then you guide the small rod brush towards the cervix to check that, and then just teaching some colleagues it's normal to say, hi, Sasa, can we remember to do your prostate exam the next visit you have, because you are a female, it doesn't mean you don't have the prostate. You still have the prostate, and we must be respectful enough to say, Mrs. Buso, may we kindly do your prostate exam in the next consultation and take bloods for that and examine the prostate if we have to.
You should please let us know once you maybe have like a long list or quite a few people from Free State, so that we can like set you up with like a place that we can meet you and the clients can see you. You know what I mean? Because we do want doctors to know each other, right? Because there'll be doctors here that are going to make our clients wait forever. But if you are coming, maybe they'll be generous enough to offer you a space. So like let's make that possible. Let's talk about that.
Yes, we are helping a lot of people, with because the most important thing is about monitoring HRT. There's a lot of side effects with it. Yes. So we're helping a lot of people that do not know what to prescribe, how much, where to start. And, there has been a shortage of the testosterone depot in the public sector, but we have other companies that have been producing. So we've been writing scripts for them, and they send it to the company, and the company will courier it within 3 to 5 days to them. Even in KZN, even in Joburg was faster, but the company still delivered. You just deposited your money into Absa Bank, and then we gave them the prescription, and they got it. Then our clinics, they would assist with injections. At times, we even phone the other pharmacists. I want to say thanks to Clicks Pharmacy in Coxted and Elusikisiki, they've been so good. They don't turn away our clients as soon as we've given them a prescription and we say thumbs up to the blood. They continue to inject our clients. We are still struggling a bit with the South African blood services in terms of if the creatinine, when people are taking testosterone, they tend to have thick blood, so they have to go and donate blood. So we tend to have a difficulty with them actually pulling the bloods for donation. And sometimes, even if it's not donored, we just want them to pull blood in a safe environment, because it's difficult to do it in the private practice because the person has to be there, you have to monitor them. Whereas in the donation services, they actually have all the equipment to do that and the time as well. So we're just hoping that I would not have a problem in Umtata. We've sent people and they have pulled blood from them. You just need to be able to specify, to say how many pints and what was the hematocrit. Yeah.
Tell me, have you what's your feeling around the hormone blockers? Because a lot of parents are always afraid that if you're still young and you like in your early teens, because I know that once you are feeling like, okay, mommy, I'm not a boy, I'm a girl. You can say that from as early as possible. But then some parents will be so afraid to get you on the hormone blockers. But every time I speak to trans people who have either like finally, look the way they look because of how long they've been on the hormone, or they've gone so far as even to have the surgery, most of them always say, I wish I'd done it sooner. And the soonest it can possibly be is the gender blockers. How easy is it, and how possible is it without the parents kind of saying, no, first turn 18, I won't allow it?
Okay, first, according to the Child Care Act, a child as young as 12 years old can permit to even surgery. That is why we don't ask for parents' consent if the child comes pregnant and they wanted to have a TOP. We no longer required to do that. So the Child Care Act actually protects children. And most times that is when you start seeing some signs of puberty. So if the children actually are wanting to, when you are helping them decide, we do what is called halting puberty. So you make them, the puberty does not develop, until such a time that they are able to deal with mentally and psychologically. Because some children, once they start to develop beard and they're not ready for it, they don't want it, then they can actually be suicidal, run away from home and all the stuff. And most of the time you'll find out they also have HIV to deal with that they got from their parents or whatever happened, So we do have, especially in the Western Cape, it's very well established at the Tygerberg Hospital, So there is places where children can be assisted to halt puberty. So we also work with the endocrinologist. Like, I am a general practitioner, but I know quite a few things, let me say, about hormonal therapy and how to assist children when halting puberty. But I don't work on my own when I'm working with children. I always make sure I consult a pediatric endocrinologist, a pediatrician, because you also do not want to interfere with other hormones where the child is growing, their bones are fusing and stuff like that. But it is possible, and it is done even in the public sector. You can halt puberty so that someone does not experience the characteristics that they do not want until they are of age to deal with it, and then they can decide.
And that doesn't have any irreversible effects like sterility or infertility or things like that?
Remember, you are not taking away the hormones. You're not replacing the hormones. Remember, when we talk about hormonal replacement therapy, all humans, whether you are male or female, you have both hormones. You've got male and female hormones in your body. Then if you are male, the dominant hormones are that of being a female, of a male, right? So when you are taking HRT, you are basically trying to block all the male hormones and make the female hormones that are in your body to work more. You're giving them a chance to compete, because the dominant one has always been the testosterone. Now you want then the female hormones to be the ones that are actually dominant, because you have them anyway. So it's not like you are introducing something that is totally strange to the body. No, it's there. It's just that it was in minute amounts, and then hence you assessed it. So when you are giving hormone blockers, it means you are blocking the end product from making you to develop breasts or to come out beard. And if you can see females that have got beard, it's hirsutism. Why would they develop beard if they didn't have any male hormones? And anyway, as we grow, because now the female hormone is gone down, you are menopausal, and your more of the male hormones are becoming prominent. That's why nothing more, nothing less.
Yeah.
No, so it's not something that damages them in any way. And then when it's different from hormonal therapy, where because you are now replacing those hormones and making them, it's like when you have a stroke. When you have a stroke, the side that has a stroke, it becomes thin and limp because it's not being used. You understand? So it's the same thing when you are using HRT, because you are blocking it off completely. There's no production, and you are adding on the new one. Hence, now we always advise people that are going to start HRT to go try freeze your eggs, before you actually start the hormonal therapy,
But
even
where
though
do
those
you freeze your eggs? Where? It's so
private
expensive.
labs, I know it's very difficult. It's like milk banks. Breast milk is so important, but there's still so many people that don't want to give out their breast milk, whereas there's women that can produce breast milk. So it's the same thing. Breast milk banks now are in hospitals, but it's a new thing. So let's just hope with new developers, the fourth industrial revolution, there's going to be people who are more interested in humans as a whole and be able to set aside those services so that they're at an affordable service.
Yes, because that's what I wanted to ask for. Like my last few questions are more around because you're working in so many provinces around the country, and here us in the Free State, we always have to look outside to find doctors outside who want to help us, with this interview, for example, we are hoping that we can even just inspire local doctors to kind of see that you are not doing anything specialized, that you need to get specialized training to work with the gender diverse community. It's just your general work. So is there something that we can access that we as gender minorities and as an organization that is like available like nationally, like whether it's a movement for information or it's like as a consortium of doctors that talk to each other that we can access from here in the Free State?
You know what? We can't run away from where we are coming from. The disparities of colonialism and racism are still there, even in the medical field. I don't want to hide that. Okay. But it's also a choice from people whether they want to involve them or not. Because the HIV Clinician Society, it is for every clinician. And people would say, I'm not interested in HIV, but almost all our clients, they will have HIV. Even if you do not ask them in your practice, I know there's other general practitioners who would treat the person for TB and treat them for hypertension and diabetes. But when it comes to HIV, they'll tell them, no, go to Dr. Buso, I don't do that. Or I don't know what drugs to change you into. Or the person now develops renal failure and they're still on tenofovir and things like that. So we're seeing a lot of that. So we need to develop and stereotype ourselves, decolonize ourselves, and know that the information is there and it's available. And for now, the guidelines on HRT at primary healthcare level are out and they are there. So the doctors that need training and assistance, because it's about coaching, I also did not learn this at school. I learned it after, having clients. I had to go and read at times. I remember I had to phone like Dr. Singh that was in Cape Town sometime back in 2009 and say, did I dose correctly? And I found out I was so underdosing my clients because I was so scared of these hormones and stuff like that. But now I tell you, I know people that have already, self-medicating, and you want me to tell them to start them on the lowest dose. I'm taking that person back, and I'd not do that because I'm confident in knowing how to monitor them and what dosages they're supposed to be on. And, I take clients back and say, because now you are starting, you must just be on 2 milligrams of the estradiol when someone is already on 6 milligrams. I maintain on them on that, but I also make sure that their bloods are correct, everything. And then if I have to tell them to say, you have been overdosing yourself, let's cut back a bit, and then I'll explain to them and we'll monitor it, and then we'll get them on track again.
Okay, no, that's great, because with this conversation, like I said, it's a media platform, it's a free platform, but you find that because we are in the minority as a diverse genders, it's not a public topic that people find interesting. So the media does need to get involved in making trans lives, non-binary lives, intersex lives more visible in a positive manner. I'm actively doing this in a small scale, but media at large can do something. What do you wish could be possible when it comes to media and this kind of information?
Non-gatekeeping, knowing that your child could be taking the hormones and you do not know. They can actually be at home and be practicing all the sexual acts that you have never seen. So knowing that we are a community that exists, and being an ally, like Nosana, I've been asked so many times, even at an HIV/AIDS conference once in Durban, one of the clinicians actually asked me, so Dr. Buso, how long have you been HIV positive? And I was like, the last time I checked yesterday, I was still negative. And then they were so shy to look at me again because they thought, since I know so much about viral resistance and ARVs and swapping this and changing it with that, I must have been HIV positive. So when you tend to work with a topic that has got stigma, people associate you with that, and most people can't deal with it. So I sometimes I do understand colleagues, but for me, if people call me, oh, you look like these gay people, you know, when I have this hairstyle, and they're like, oh, why are you now lesbian? Have you transitioned and whatever? And I tell them, I transitioned a long time ago. I transitioned myself because I had to understand that people are people, and what people want, people get, you know, and to make my life easier, then I had to be a transsexual in my mind.
Absolutely right. Yes, that is it. A good friend of mine was saying, Nosana, I'm not trans. Anyone that has to understand me needs to transition to understand me. I'm myself. I'm staying the same. So if anybody needs to change, it's other people's attitudes. The other people are transitioning. So the trans community, I love that a trans person is just becoming themselves. It's us that transition to accept them, right?
Understand that yes. So to just try and answer some of the questions, to say that media needs to understand that when monies are allocated, we must go over looking at who has been providing, who has been out about it. Being yourself is not about being white. It's not about being born in a certain culture. It's about identifying with who you are, and money needs to go there. And if we are continuing to shy away from things that we don't want to speak about, then a lot gets damaged. I think you know one of the things that I experienced when I was doing TOPs, they actually took us into a ward that was by the toilets, you know, by the ablution facilities in the part of the hospital. But that was before I came, and I was asking, how do you put people there? Because already you are telling them there's something wrong that is being provided, you know, that is being there. And in that small town of Mount Frere, there were so many septic maternal deaths because people do not want to provide proper TOP, and children were getting raped by these backstreet abortionists because they would tell them, no, the cytotech needs to go straight into your cervix, and my penis is the longest thing that would get into there. So they would put the cytotech onto their penis, rape the person again who is coming to get the services. We had a lot of children that we found in the toilets because they were doing abortions at a non-legal age when the child was already like 7 and 8 months. So if we do not put money, or when there is funding, we tend to give it to people we know, even though they're not reaching the communities, then we're doing people a disservice. So e-service provision needs to go to the people. And
it needs to go to the scary topics, the stuff that people are afraid of. And if you get money, you must remember that there's some things that everybody's avoiding and afraid to do, and you should commit to actually putting money there to save people's lives.
Yes. You know, one other time I was talking to my priest and saying, they don't, because I'm a member of the Mothers Union in the church, then I'm practicing legal terminations of pregnancy. It means I'm not holy enough. Then I told him that it is okay if people feel like that, but all I know is that the children that you come and anoint in ICU, it's because they've got septic abortions and they're brought by their mothers, who are also a Mothers Union. So is it better for someone for you as the priest to come and anoint them to die, or to talk about contraception in church, and then the child is assisted long before, or a report that they've been raped by their father to be pregnant in the first place, and now they are trying to do a backstreet abortion, and now you as a priest to come and pray for them because they are in their dying bed.
So are you doing some activism and information sharing in the church space? Because that's a very difficult space to kind of share this kind of information.
Church is the easiest space. Church is the easiest space because people understand that God accepts us as we are, who we are. In fact, I don't want to lie, my church, the Anglican Church, accepts people for who they are because they know that God created us, and it's only God that knows us from deep within. And God, when he formed us, he knew who we are before even our parents saw what our faces looked like.
No, for sure. No, then my second last question before you have your final comments. What's needed in South Africa? Because now I feel like if you can just summarize, because HRT is scarce and it's not available at primary healthcare facilities. And with the gender exchange, we are trying to kind of share the information so that people kind of know that actually HRT is actually an essential medicine. In fact, we were not even wanting to call it HRT. We wanted to call it gender affirming medical treatment, because when it's called HRT, our transgender community, they're at the back of the queue with people with cancer jumping them and men with erectile dysfunction or sterility issues and women on menopause, they jump the queue because it's seeming more important. So what steps can be taken in South Africa for gender affirming medical treatment, and even some of the other stuff that you're talking about? You know, you already mentioned that actually, if you've got money, just use it to help where you can.
Yeah. And decolonization of the mind, because at times people are educated, but they have no knowledge, you know. So it's very important for people to be knowledgeable. There's a lot of people that have got master's degree, but they have no knowledge of what they are dealing with, or who is part of their community. For an example, if you've got a CEO of the hospital who is not aware the kind of population that they are serving, then it defeats the purpose. So the knowledge is something that we gain on a day-to-day basis. And if we try and learn and relearn things and know that we learn from people that we least expect to learn from. So if you're able to hear the next person's voice, then you are better off because you'll be able to learn. That is wisdom. But if you think you're always right because of what you were learned and taught, that is not even part of you, who you are, then it becomes so difficult, because you'd find out some people have been born and their umbilical cord is at the corner of the crawl in their deepest rural areas. But when they tell you, they will tell you about how Jesus hates you because you've changed from the form that you are. And they don't even know who created you and how Jesus created you. They don't even know what your relationship with God is, but they are able to put that judgment. So if we are able to learn that there's so much that we do not know, and every one of us is at God's mercy, then we'll be able to learn new things that will make us to be able to be humble enough to respect everyone. So decolonization of the mind, relearning and learning and unlearning and learning and relearning and being humble will give you better wisdom for people to honor you and people to respect you. So if leaders really want that, then they should start looking and knowing the peoples that they serve.
This is exactly what you were talking about the emotional intelligence, the spiritual intelligence, because you just need to be open for that, right? And these guidelines, they kind of need to go start being taught in medical school. You can't be learning these guidelines after you've gotten your medical degree, don't you think?
Public health in the University of KwaZulu-Natal is really trying hard to do that. Thanks to Dr. Luvuno, who's got masters in gender diverse care. She's really trying hard, you know. I know Professor Dlova is really out there and really trying to relook at the curriculum. And I'm happy to say, even though I'm not part of the lecturers, but I have got an opportunity to meet different students from different universities to come and learn on how we are managing gender diverse people. So there is some transitioning and there is some change, but it is a very slow pace. Let's just hope that higher education, you know, will embrace and take into account that there is sex and sexuality besides sexual reproductive health, and that women also do have sexual dysfunctioning, and transgender people, besides the fact that they need a hormone gender affirming care, they also go through sexual dysfunctioning, and we need to be able to deal with those issues on a general basis.
Sure, this has been a very, this conversation, I was hoping that some of the parts were going to be lighter. It never got light at any point. It was heavy. It was heavy and it was painful, because we are still got so far to go, things are inaccessible. The quality of the care is still at such a poor level. And, even when there's a post-grad or a master's student or somebody doing their PhD in HIV positive transgender people, for example, you find that they've got so little to offer the person who they are studying. Do you know what I mean? And then they're going to run off and be paid however much for having the qualification in transgender HIV care, but the transgender person is still sitting in the rural community and still suffering from the very things that they think that they talk to one student about. That actually breaks my heart, that I wish master students and people that are doing their studies could actually just give credit, even if it's something a bit more than what they offer, because our clients are used,
I think, remember, there's an ethics committee, and when someone is bringing your research to you, they have to sort of show what benefit is it going to be to the community and to yourself as a participant, and that's the information that we're usually not confident to ask. And at times, it's also, that the people, the trials or the research that actually involve where people get a little bit, some stipend, it's not generally open to everybody, because they would say everyone is going to run to that study and stuff like that. But I think it is only fair that if a study with some stipend is available and it's for transgender or gender diverse people, then they be given an equal opportunity from different communities. But at times, the people that hold the purse will dictate from where and how they want it, because sometimes they want to finish the study quickly and get paid and things like that. But I think if we as the gender diverse community and allies start, becoming involved and ensure that some of the things that we talk about, we actually implement ourselves, encourage people to go to school, stop with the handouts, participate, go to school, work, wherever you're working, doesn't matter the kind of job, as long as there's something that you are earning and bringing to the table. Sometimes, it's difficult to find jobs. People have gone to school and they don't find jobs, but let's go out there and be competitive. And at times, being competitive is about having more information, informing yourself more, learning better, and showing people that you are able to be taught and learn. Because sometimes it's not about me being a professor, it's about people seeing potential that I'm able to be taught, even though I've not qualified as a professor, but they can see potential in me. So we must always put our minds at that level, so that people see that we are ready to learn and we are ready to work hard to be able to achieve the things that we are able to get. And like I'm saying, even myself, at times, someone would tell me I'm gender non-confirming, and I'll still maybe speak to them or about them and say she or he. But as soon as I realize I've not done correctly, and then I'll just apologize and continue and say the correct pronoun for them. So we are in a process of learning. My sisters that have done accounting and economics, they usually say we are work in progress, Yes. So myself too, I'm work in progress. So if we can all realize that we are work in progress, then we are in a better position.
Dr. Nomsa, thank you, because I think when you also mention and you remember that sometimes we offer free services at Tholwana and Molemo, and the more psychosocial support we offer, the more counseling we offer, and the more personalized incentives that we wish to provide. You know, we are providing makeup, eyeliner, blush, nails, you know, and I think this sometimes does create a dependency, you know. So with even this conversation, if somebody can just take the time, listen, and realize the more you empower yourself with information, the less that you'll be knocking on anyone else's door to say, please give me, can I have, what can you give me for free? So this is
at times, let's use it as an exchange mechanism, you know, Nosi, where you need to earn the things that we have, we must learn to earn them. So if we do not learn that, then we're creating a dying society. I, for one, I don't like gardening, but I always, you know, ensure to I know what is being planted during that season. I'm one of the first people to provide the seeds, you know. I'm one of the people to assist people to get sprinklers, or if there's anything in the Department of Agriculture that is being given vouchers or things like that, I make people apply, you know. I support in that way because I'm aware that it makes a difference. Even though I myself, I'm not highly equipped to do that, I do a lot of reading to say, okay, in this kind of environment, which plants are actually going to thrive better, because I don't want people to come and get food parcels and then in the next month they're unable to do that. So in the food parcels that I usually provide, I always make sure there's a seed, something that they can plant and you know, have a sustainable garden. And I go back and monitor that because I really believe that there's a lot that we can still teach our people to do, even though it is tough and difficult.
And unfortunately, the gender diverse community, it's so external sometimes, the practice that you are expressing, you know, because there's a way you feel inside, then your whole about mission is about, can you see who I am inside? And it has to come with the accessories and the look. And I just really want to say that if you're watching this and you need our services, you need HRT, which is so scarce, and you need even the surgery, which is so scarce, the more you equip yourself with information, you know, the better, you know.
Yeah.
I'm going to put
I'm really hoping that one day you'll be in a comfortable space to share and tell us what happened to your chest reconstruction.
My top surgery.
Yes, and
yes,
you know how
I give much better height.
Yes, you know, to how you went about that, because most times people think that the public service is not doing anything and people are having negative attitudes. And I want to tell you, I'm working the public service. The service you got was in a public space, you know.
It was great in Amtata.
Yes, Nelson Mandela Academic. You know, we've got specialists now. You know, we've got super specialized specialists, vascular surgeons, about Dr. Mtimba. We've got Dr. Slolo, who's back from Cape Town as our urologist. It is amazing. We don't have to cry twice for an orchiectomy. You know, Dr. Magibi will do it at a peripheral hospital in Libode, of all places, and no one will ever think that, you know, orchiectomies are happening there. So the public service is good. Our government is for our people, and we are using those services. And there's very good public servants that have got a great attitude, and we are walking the walk with them. So we are work in progress.
No, absolutely. I was a bit of an activist when I was needing to explain to different people why I'm having them removed. I was like, yes, like, oh, is it a choice? It's not cancer. I was like, I had to start from scratch and give my speech. So I definitely know there's two other of my clients' friends this side who've also had top surgery this year. So maybe you're inspiring me. Maybe the three of us, that's going to be our next conversation, that we just talk around what our journey was. It's a long wait. It's not an easy task. If you're in a hurry, then you're knocking on the wrong door if you think public service is for you sometimes, you know, and you just have to have the patience and you just have to know why you're doing it. I certainly knew I didn't want children. There's all these things, you know, that we can get into. And if you want to interview us, I will give you that opportunity.
Yeah, so we can definitely do that, and hoping also our colleagues and allies that have done bottom surgery, they would be able to share someday. We've got quite a
Yes, I
few
have someone who's
women
willing
and
to talk
trans
about the bottom
males,
surgery. Yeah.
who want to know, and who, sometimes, because there's all these scary social talks about how you would change who you are and how you would look abnormal and all these things. So
Yeah.
when we see the practicality of the great job that is done by our clinicians, more people will definitely have amazing lives.
No, I absolutely agree. Thank you so much, Dr. Nomsa. It's always wonderful to talk to you. You're a little bit fuzzy there on your camera. So we're going to have to meet in person sometime. We're going to see how that's going to happen. I'd love to see you again. And if you're passing through Bloemfontein, please come and say hi. Thank you so much for your time today. Thank you for your expertise. We really appreciate it.
Thank you so much. I hope it provided some assistance. And I know in one of your last talks was, how do we use these letters in the new guidelines? What do we do to
Yes, sorry.
get
Yes, I
them?
did have that question.
Yes,
Hashtag has
but
created 3 letters, one for hormone blocking, one for gender affirming medical treatment, and one for gender affirming surgery. And it's directly for if you have medical aid, that you are trying to get medical aid to help you. If you want medical aid basically to cover it.
yes.
Would you like to give us some info on that also?
Yes, I just wanted to say the most important thing about hormonal therapy, you have to be under monitoring. And it is a responsibility that whenever, it's like people think that when you take a Panado, there's no consequences. Some people get fulminant liver failure just from taking Panado. So when you're taking hormones as well, we need to be in a sort of accountable position to say, we've been monitoring you and you're doing it. You are taking your hormones and you're being monitored well. Because remember, if you're going for surgery, complications from anesthesia can occur, and whatever you are taking, the drug-to-drug interactions, the surgeons need to know, the anesthesiologist needs to know. So all you do is just take it to your doctor, and then they'll do the blood profile for you, or even the person that's going to be performing the surgery. Then you just take it to them, and then they will just sign it for you, and you go. Even for the gender markers, your normal clinician, because everyone, all of us, even as doctors, we go for debriefing. You need to have someone to check you all the time, that you are still in check, because at times we think that we are all coping and all these pressures. So mental health is a real big issue across industries, and people need to learn to take care of themselves and put it as routine of their normal day-to-day care, to say, I have a psychologist. I went to the psychologist to check myself, not because I was feeling psychotic or depressed, and just to check yourself like you do a normal checkup. So it's the same thing that I always teach to gender diverse people, that take psychological consult as your normal checklist, like you would do if you were doing a prostate, like you would do if I was doing a pap smear as a female and stuff like that, like you would do if you're doing an anal smear if you were a male having sex with males. So take it as a normal consultation. Don't get offended when they say, no, speak to your doctor, speak to your psychologist to say, are you okay? Are you are you sure about what you are doing? So don't feel offended. Take it as a normal day-to-day assessment and continue with it.
And there is still a bit of stigma to seeing a social worker or a psychologist, because with the services that we provide as well, our clients need to know that, listen, we did a risk assessment on you. We think maybe you could benefit from talking to a social worker. But then some people, as soon as they get the call, oh, social worker, no, I'm fine. They get defensive. You know what I mean?
Yeah.
Just know that I would love to get a call from a social worker that would listen. You know what I mean?
Yeah.
Please just take that as you just got some. You
got someone who really cares about you. They make a recommendation. I struggled with weight for most of my life, And the psychologist then was, you know, why do you think you're not losing weight? And you know what? As a doctor, I hadn't gone and done my hormonal checking, only to find out I was hypothyroid, my metabolism was low. As a doctor, I could say I'm not losing weight. I could say I'm not losing weight. I'm not eating much. I'm exercising. I'm running 21 kilometers and doing all this, but I'm not losing weight. But as a doctor, I never went for my hormonal checkup. And until my psychologist said, okay, let's start with the basics. Let's see at your, what's your biology like? Have you ever gone for your test? And then like, boom, that's what. So at times we need people to help us in our lives, not because we are psychotic or we are less important or we just need people to be able to help us guide and do better with our lives.
And we here at Tholwana, we have got 2 social workers. So please remember, guys, just sometimes just call and say, I just actually want to check if I'm okay. Can you just ask me questions? You don't have to be calling our social worker just because there's a crisis. So thank you, Dr. Nomsa. That's also going to be one of the little add-ons that we're going to say. Please, just call us and just check to see if you're okay, even when you're feeling fine.
Yeah.
Yes.
Thank you so much. Thank you so much.
It was very wonderful having you.
Thank you. Namaste.
Take care. Have a good night. Thank you very much. Okay, bye-bye.